Morning everybody, welcome to this shoulder day of our workshop. So important thing here is now we are talking about rotator cuff injuries, rotator cuff tears, and we will be talking about the techniques to repair the cuff and how we can make that our we can ensure that our repairs are strong and they don't fail. So if we talk about rotator cuff injuries, traditionally they were repaired with open techniques. So a transtibial technique, trans-osseous technique was used to repair, and that was used without anchors. With the advent of arthroscopy, the techniques have evolved, and if you talk with me, that there are 4 generations of arthroscopic rotator cuff repair. The first generation was a single row repair. The second generation was a double row repair, in which there are 2 levels, medial and lateral row anchors, which are not linked to each other. They have a separate point of fixation. The third generation anchors was a medial row which was tied, and the threads which are tied are put into the lateral row. And the fourth generation nowadays is sort of a tape lock technique, in which the tapes are tied without knotting into the lateral row. So these are basically the generations, but we will talk very basic principles that how we can improve the tendon healing and how we can repair those tears which were previously considered irreparable. So irreparable rotator cuffs are large tears. They are 3 to 5 centimeters in 2 or more planes, 3 centimeters in width and length. Massive tears are more than 5 centimeters, and irreducible tears are those tears, those when you pull those tears and you are not able to bring them to the insertion. Now this can happen if you are not vigilant. So if you put them under tension, this is bound to occur. You can say that the rotator cuff is pulling the anchor this way and the anchor pulls out in this direction. So the pull out is usually this. So do you know about what is dead man's angle?
Sir, dead man's angle is from the card.
Yes.
45 degrees.
So what is dead man's angle? Actually here the dead man's angle is very good.
Yes, sir.
Still it pulls out. So the dead man's angle is if you have this line. So you have to put an angle. So this is the line of force of the rotator cuff. So if you put an angle like this, it has a high tendency to pull out. If you put an angle like this, it has less tendency to pull out. Okay. So in the anchor insertion direction should be opposite of the strength of forces of the rotator cuff. Okay. So this is the rotator cuff force in this particular patient, and that is why the anchor pulls out like this, and this is the direction of anchor. If the anchor is supposedly pulled like this, then they had a high chances of pull out. So dead man's angle is very important. You need to put an anchor at a reverse direction of the direction of pull of the tendon. So this is the follow-up. This we did a revision. So now this is very important. What all you should do to reduce the forces. Basically, in a rotator cuff repair, if you want to repair them successfully, you need to repair them in a low tension. If you repair them in a high tension, they are bound to fail. So you need to repair them in low tension. You just have to pull them and put it. If you pull them very hard and just put the sutures and put tight knots, they are bound to fail. So important thing is not the repair, but the releases. So the important thing is not the repair but releases. So the superior and inferior capsular releases is very important. So you need to release the capsular tissue from between the cuff and the capsule and between the cuff and the acromion. So all the soft tissue surrounding you need to release. And then you can do these 2 procedures. This is called the anterior and posterior interval slides. These are basically releasing the tissue anteriorly and posteriorly. So basically if you release them, they will become more mobile and the excursion of the cuff tissue will increase. This is also very important. So this is your shoulder, and this is the ideal footprint. But if you are very tight, the rotator cuff is not covering up. So you can put your anchor here also. So you can medialize the anchor insertion by about a centimeter. So that will reduce the forces on the anchor. If you want to put the anchor right where it is at the tuberosity, then the repair will be in lot of tension and it is bound to fail. So this is important. So you can medialize the footprint, and Margin convergence. Anybody of you knows what is margin convergence?
Converting a U shape to.
Very good. So, what is important is, if your tear is a U-shaped tear, the biggest mistake that we do is we try to pull like this, repair anchors here. So there will be a lot of forces here. So better to repair them in a shoelace fashion, like this. So there you close them side to side, and then you will have a small tear remaining which you can close with an anchor. Now margin convergence can be done in two ways. Can you tell me what two techniques of margin convergence?
Oblique.
No. So margin convergence, you have a tear like this, okay, and this is your humeral head, okay. Now you need to close it like this. So you can do it either with a free thread or a free fiber wire, or you can put an anchor here and one suture here and one suture here, and then you close it like this. So margin sutures can be done either with a free anchor, either with a free wire or with an anchor. So two threads going in both directions and closing it up. Okay. So either with a free wire or with an anchor. So both the techniques are viable. If it is a very large U, then you can use both the techniques. So initial you can, at the top, at the apex, you use a free, and then at the bottom you use anchor and close both the sides together. Okay. Now, is this video clear? Not very clear? This is the background. So now, this is what I call this as a posterior interval slide. So this is a large tear, and you can see that the cuff is medial to the glenoid, very large tear. Okay, and if you pull it, it will not come to the glenoid. So for here we do a releases, interval slides. Now interval slides means that we need to cut the tissue between the supraspinatus and infraspinatus, posterior interval slide. This means that we cut the tissue between the supra and the infra. So the supra becomes separate from infra, and separated pulled, they will have a better insertion. Then they will pull together. So if you talk about supra and infra, they have a different insertion. Supraspinatus is in the supraspinatus fossa, infraspinatus is in the infraspinatus fossa. But when they attach, they have a common attachment on the greater tuberosity. You cannot make out where the supra ends and when the infra starts. So what we do here is we put two sutures, traction sutures, and this is the scissors. The scissors cut between the two muscles, supra and infra, and it cuts its way up till the scapular spine. So the scapular spine is a demarcation. Above the scapular spine is the supra. Below the scapular spine is the infra. You go with the scissors and cut it up to the scapular spine. You have supra separate, infra separate, and then you pull it and repair it. Okay. Okay. And then the excursion increases. So if you do this, the excursion will increase about 1 to 2 centimeters. So this is called as a posterior interval slide. Anterior interval slide is, actually I'll show you. So this is. So this is basically a procedure which is called as a biceps SCR. So this is again a procedure for a massive rotator cuff tear. So the biceps tendon can be used as a SCR. So what you do, as I told you, we did a superior capsular release. So you release the capsule between the cuff and the glenoid, superior glenoid. After that, instead of doing the tenotomy at the site of the insertion, you do a tenotomy at the humeral head. Okay. This is the biceps tendon. And the biceps tendon is explored in the bicipital groove. And you cut the biceps tenotomy in the bicipital groove. So you will have about 2 inches, about 1 to 2 inches of the biceps. And this biceps is tied at the level of greater tuberosity. So if you see here, this is the biceps. The biceps insertion is laid intact. and it is tied here with anchors. So the biceps will serve as a biceps. The biceps will serve as a biceps SCR here. Okay. Because so you make a lasso loop into the sutures of the biceps, and then you repair the loops into the. So these sutures are repaired with the anchor right here. Okay. So these are suture passers that we use to pass the sutures through the. Take them out and then you repair them sequentially. Okay. What is this stitch called? This is called a lasso loop stitch. You know what is a lasso loop stitch?
Not a lasso loop.
Huh.
You take a loop.
Loop.
Through the loop again you take
a bite. So what is the advantage of this technique?
Cut through will be less.
Exactly. So there is no cut through. So this is the final repair. So this biceps is repaired on the gripper. So what it does, it brings the shoulder down and it stabilizes the shoulder. So this is, instead of doing a regular SCR from taking a tension pressure attack, you just use the biceps to do a SCR. Okay, so this is how you do it. So here you can see that the massive rotator cuff is classical sign. You have a reduced space. It's a very classical sign of a massive rotator cuff tear. And if you do it properly, then you have an increased space. This is very important. So, what is SCR? Superior capsule reconstruction. It is basically an advanced procedure in which we take a tension fasciolata graft and we put it in the shoulder between the glenoid and the humeral head. So this basically works as a spacer and it pulls the shoulder down, it pulls the humeral head down, thereby balancing the forces. So this concept was given by Dr. Mehata. This is called as a reverse trampoline effect. So what we do is we take the tensor fasciolata here, we quadruple it, make a graft like this, and this graft is inserted inside the shoulder like this. So this graft is inserted into the shoulder, fixed on the humerus head and fixed on the glenoid. So it acts like a support. And besides that, you can do your rotator cuff repair. So this is the initial TFL graft which is harvested, TFS fascia. Then it is four-folded. This is the final graft, and this is the graft which is inserted. So we put 2 anchors in the glenoid, 4 anchors in the humerus. So this is a small video in which we just show you how the graft is transferred into the space. So this is a cannula, and through this cannula, the graft is transferred into the shoulder with a fixed point on the glenoid and fixed point on the. So this is the graft, and this graft is pulled. So this is the final picture. So this is the fixation on the glenoid here, and then so this is the fix. So you pull it on that side. Okay. You pull it on that side. This way you fix it upon to the glenoid, and this side you fix it upon the pubis. And then you put knots to repair it. Okay, so glenoid probably 2 anchors and 3 to 4 anchors on the humeral head. So this is a classical finding. If you see here, The acromion is touching the humeral head. This is a classical finding of a massive rotator cuff. Now this is a picture post SCR and you see a very good space here. This is a very classical. The SCR fits like this here, from here to here, and you have a good space. So that's a very classical. So it's a reversal of the proximally migrated humeral head and restoration of the acromion thickness. That is a classical thing that we want to achieve. So this is the pre and this is the post-op. This is 6 months follow-up, this is 1 year follow-up. After an SCR. This is just a small video. This procedure is called as an extra-articular arthrolysis. This is a procedure which we do in cases of stiff shoulder. So stiff shoulder, you have a problem of entering into the joint, like in that case in the NH that we are doing, and you're not able to negotiate the trocar into the joint. So this technique can be done if the shoulder is too tight that the trocar cannot be manipulated into the joint. This is called as an extra-articular arthrolysis, and actually the first description was given by Dr. Lafus. So in this technique, what we do is we go subacromially. In even very tight shoulder, you can do a subacromial decompression. That is not a problem. So you do a subacromial decompression, then you make the lateral portal your viewing portal, and then you dissect it anteriorly, dissect the tissues anteriorly. Once you dissect the tissue anteriorly, you will be able to see the biceps, and then the biceps, through the biceps you can enter into the rotator interval. So you cut the biceps, tenotomy, you go into the rotator interval. So by the rotator interval, through the rotator interval you go into the joint and start releasing the capsule. So this will be possible even in very tight shoulders in which the shoulder cannot negotiate into the lateral portal. So what we do here is we are doing initially the tenotomy, then we are exposing the rotator interval, and then we are going into the joint. So this is we are going into the rotator interval area. So this is the rotator interval area. And even in very tight shoulders, you will be able to do this procedure without any problem. So this, you can see, this is the biceps. The biceps is split here. You cut the biceps. And then through that rotator interval you go into the joint. So you from the top you are looking down, and then you make another accessory portal to clear the tissue. So this it is cut, and now here you go down, identify the superior glenohumeral ligament, release that, MGHL, release that, and once you release the MGHL and the capsule from the anterior, then the shoulder will become a little bit loose, and then you can insert more portals posteriorly and anteriorly. So this is a release anteriorly, posteriorly. So once you are done with the release, then you can put your Wissinger rod from the back. And then you can release it as you release it naturally. So even if the shoulder joint is very tight, you can do this kind of a capsular release surgery with an extra articular arthrolysis technique. So this is a very good technique if the shoulder is very tight and you are not able to negotiate your instruments in. So here you can see that this is the humeral head, this is the glenoid, and they have done almost a 360-degree release of the tissue. This is the subscapularis, if you can see, and from there, this is the subscap, this is the humeral head, and this structure is the MGHL. This is the MGHL, and we are cutting the MGHL now. So we go in here like this, and we cut the MGHL. This is the MGHL, and the MGHL is cut like this. Okay. And then we go down and we release the IGHL. So from the lateral viewing portal, anterolateral viewing portal, we can release it all down. And once we release this, then the shoulder will become little lax, and then you can put other portals. So subscapularis, identify and release the perisubscapularis. So subscapularis release from the front and the back. Okay, this structure that you see down is the IGHL. So you release the MGHL. Now this structure is the IGHL band. Okay, this is the subscap. MGHL we have released. So inferior margin, this is the anterior band of the IGHL. So if you see your shoulder, I'll just demonstrate. So this is the IGHL band, this one, and in the end you release that band. So this is the IGHL anterior. So once you release this, then the shoulder will become lax, and then you can make other portals posteriorly and anteriorly. So this way, even very stiff shoulders can be addressed. So that's it. That's it. Any questions?
The anterior slide along with posterior slide leads to the vascular compromise.
So very good question. But actually, the vascularity of the subscapularis, of the tendons, usually comes from the medial side. So usually that is not an issue. The other thing that we have changed. So what we have changed nowadays is this. If you see the posterior part of the scapula, this is the spine of the scapula. This is the suprascapular notch. So this is your scapula. This is the suprascapular notch. Okay. So the supraspinatus fossa is like this. The supraspinatus will origin like this and will attach onto the humeral head like this. Okay. This is the infraspinatus origin. It will go like this, and it will go like this and arrange like this, attach like this. Okay. Now the important thing is at the GT. Initially it was believed that about half of the GT is supra and half of the GT is infra. But nowadays it is proven that this GT is the supraspinatus origin is less. So this is the work of Dr. Subair. So he proved that the GT, the insertion of supra is actually at a very small place, and the infraspinatus fans out. So it goes more anteriorly. So now we are doing a slide more curved anteriorly like this. Previously we used to do a straight slide like this. Now we are curved slide like this. Then there is one procedure which is called as the anterior interval slide in continuity. So that we do to preserve the vascularity and preserve the band between the supra and infra. So if the subscapularis is torn along with the supra, then you release the rotator interval, but you don't cut the CHL and SGHL. So the comma sign you have to keep it intact and release it medial to this. So this is called as the anterior interval slide in continuity. You do anterior interval slide, but doesn't cut the terminal connection between the supra and the subscapula. So that prevents the further pushing of the. It prevents the. So what it does, it links the supra and the subscap. So when you reduce the subscap, the supra will also reduce a little bit. So they are a linked structure. So if there is an anterior superior tear, you should repair both subscapularis and the supraspinatus. So today in the surgery we will be seeing this in detail. So how we will approach the subscapularis, how we will approach the supraspinatus, and the technical details. But this is just the concept. Okay.